when a patient comes to you with seizure, first thing you have to decide is it true seizure or it is? Yes, pseudo seizure. And once you know it is true seizure, right, then you have to see is it a recurrent tendency or it is the first one, right? Even if it is first one, it warrants thorough investigations, right? But if it is recurrent one, then of course you can think in the terms of epilepsy. Then you have to define the situation, is it partial or partial becoming generalized, or it is truly generalized case of epilepsy. Now what is the real difference in partial and generalized? As I told you previously, partial cases of epilepsy are those cases in which the onset of the attack can be referable to one hemisphere, and this onset of attack may be detected by the clinical observation or it may be due to EEG. For example, if you do EEG of a person and in electroencephalogram, you see that first abnormal electrical activity is only in right temporal and then abnormal activity spreads everywhere. It should be still considered partial, which is becoming generalized. Is that right? So how do you truly decide a case is partial or not? It is either from electrical EEG you can say evidence, or it is clinical evidence in which onset of the attack is referable to one hemisphere. But in some cases, onset of the attack cannot be referred to one hemisphere. For example, if epilepsy truly starts from diencephalon, and from diencephalon attack starts and spreads to the both hemispheres simultaneously, and both cerebral hemisphere has abnormal electrical activity which is repetitive and which is hypersynchronous, right? And in this particular case, the clinical presentation will not be able, you cannot find anything in clinical presentation which is referable only to one hemisphere and not referable to other hemisphere. Such cases in which clinical presentation or on EEG electrical activity cannot be referred to one side of hemisphere, we say it's a generalized epilepsy. Is that clear? Now, what are the different types of partial epilepsy? We'll go rapidly through that because we have discussed a lot already. As I told you, first, is it epilepsy or not? Secondly, is it partial or generalized? Then third question should be, if it is partial, if partial, then yes, is it simple or complex? Is that right? You already know that when you will take the history, you will find that patient's conscious level is not altered, it must be partial, simple. And if it is conscious level has some alteration, then it is complex. If you have answered these three questions, that patient has really epilepsy and you know that is it partial or generalized, let's suppose you decide it is partial, then you have to decide is it simple partial or complex partial. After having made this decision, then you have to confirm, yes, next is, you have to find an evidence for disturbed electrophysiology. Disturbed electrophysiology. Of course, EEG is there. With certain electrodes applied to the scalp, you determine which is the part of the central nervous system which is showing the onset of the abnormal electrical activity. Once you know this thing, the next point is you must know what is the focus of, if it is partial, you must know what is the focus of epilepsy. Is it right frontal lobe or left frontal lobe, or it is temporal lobe or occipital lobe, or which area? Is that right? So it means you have to anatomically localize. Anatomically localize the lesion. Again, actually we are moving in reverse direction from patient to the lesion. First patient came, we have to decide the clinical event which patient is presenting, is it seizure or not? If it is seizure, is it partial or generalized? If it is partial, is it simple or complex? Then whatever it is there any evidence of disturbed electrophysiology or not? Here I want to tell one thing very important. Of course, the patient who have epilepsy, during the attack, they do have disturbances or abnormal findings in EEG, right? During the ictal phase, during the during the ictal phase, during the attack phase. If you do EEG during the attack, of course, every patient with epilepsy should show some abnormal electrical activity. But if a patient during the attack shows no abnormal electrical activity, what do you think? Pseudo-seizure. That is pseudo-seizure. It's a very important point. When nothing works, you go for EEG during the attack. And here I want to tell one thing more. We were talking about status epilepticus. When a patient with status epilepticus was put on, let's suppose, very refractory case and we had to go for anesthesia, how long you will give anesthesia? In status epilepticus patient, let's suppose you have anesthetized the patient and you are ventilating him. How long you will continue that? Till there is no brain damage. Then you have to wait until brain damage occurs, then you will stop the drugs. Okay, this is a new theory, alhamdulillah, no one knows in the world, right? Yes. Any good doctor knows that when a patient with status epilepticus comes, how long you will continue to keep the patient under anesthesia? Of course, not forever. Yes, you always do concomitant EEG. EEG will tell that abnormal electrical activity has stopped or not. Nothing else will tell. If he was having tonic clonic problem, you have anesthetized him fully. Now how you know that clinical manifestations are aborted? But abnormal electrical activity may be there. So what you do? You continue the EEG. Is that right? And keep on looking for abnormal waves. Right? And if abnormal waves disappear, then you can safely bring him out of anesthesia, and of course, then you will put the patient on oral drugs. Right? But anyway, let's come back. So we're talking about role of EEG. EEG, number one, some people say that even single attack, after single attack you must go for EEG. But modern trend is that after single attack we do look for structural lesions through CT scan and MRI, and many neurologists believe EEG should be done after second attack. Anyway, you go with this thing, that first attack is there, you have to define the electrophysiology and you have to define which area of the brain is producing the trouble. So look for that area of the brain which is producing trouble, you have to anatomically localize that area. Again, EEG may help you. That abnormal electrical activity is coming from frontal lobe or temporal lobe or from the all lobes. And in this regard, even MRI and CT scan can also help. Once you have done anatomical localization, especially in those cases which are called symptomatic epilepsy. What is your concept of symptomatic epilepsy? We saw there are some epilepsy cases of symptomatic epilepsy. Have you heard of this term? Symptomatic epilepsy. Don't tell me that other cases are non-symptomatic. There is a special term used by the neurologist, symptomatic epilepsy. Write it down. When someone has some underlying abnormality, an epileptic attack is secondary to that. For example, you have a tumor, or you have infarction, or you have vascular anomaly, or you are having, you can say, infection in some part of the brain, or abscess, or hemorrhage, or infarction, anything. And due to that reason, epilepsy appears as a symptom. Then that is called symptomatic epilepsy. Symptomatic epilepsy is when there is some underlying disease which can be managed, and epilepsy is appearing as a symptom. But sometimes patients have widespread defects in central nervous system, in neuronal connections, or neural migration during intrauterine life. Look, if you are having a brain tumor and you develop epilepsy, it is considered symptomatic. If I am having vascular anomaly and due to that I develop epilepsy, that is symptomatic. But if she does not have any structural lesions, no metabolic lesion, but generally our central nervous system has weak GABAergic system throughout, do you think we will find a special disease in any corner of her brain? No. So we will say she has epilepsy, but which is not due to as a symptom of some underlying problem, which is structural or focal. Is that right? Such epilepsies are called idiopathic epilepsies. These are called idiopathic epilepsies. So some people divide the epilepsy into, yes, idiopathic epilepsies are symptomatic epilepsies. Idiopathic epilepsies are usually inherited, or idiopathic epilepsies usually do not have metabolic or structural lesions that you will correct them and epilepsy should be cured. But symptomatic epilepsy is a case in which there is some underlying disease process which is producing epilepsy as a symptom. And if you remove that disease process, epilepsy will be cured. Is that right? For example, someone has glioma and then he presents with epilepsy. If you remove the glioma, epilepsy will disappear. So epilepsy was a symptom of glioma, right? But if someone has generalized weakness of GABAergic system, what you will remove? All the brain. You cannot cure that. You may only manage with the, suppress the situation with the drugs, right? Now, so what is the next thing? You come to the real question, that once you have anatomically localized, look for the cause. Look for cause. What is the cause? Again, let me repeat it. Patient of epilepsy came. Question number 1. Is it true seizure or pseudo seizure? Number 2. If it's true seizure, is it partial or generalized? If it is partial or generalized, what type? What type? Simple or complex? Or another, is it simple or complex? 3A and 3B question should be, is it motor? Yes. Sensory? Or yes please? Excellent. Psychomotor. Right? Then you may go for evidence of disturbed electrophysiology. Then you may go for, yes, what is this? Anatomical? Localization of the lesion. And in the end, then you look for the cause. What is the cause of this? For example, if I say my right temporal lobe is the source of epileptic activity. Now, what's wrong with right temporal lobe? Is there any abscess which has come from the middle ear? Or is there any, you can say, tumor? Or is there any infection local, meningitis? Or there is AV malformations? Or there is cerebral infarction? Or there is some cerebral vein which is thrombosed? Don't make a ratta of these things. It is very easy to understand. Any pathology in central nervous system will disturb the balance between stimulatory and inhibitory system and may come up as epilepsy or seizures, right? Now, so look for the cause, right? Third, next, you have to look what is the most appropriate, of course when you're looking for cause, you're going for investigation. Most appropriate first line drug. Third, you're controlling the symptom. And next question, how to manage the cause? How to manage the underlying cause? So these are the 8 questions you have to ask yourself. If a patient comes with epilepsy, whatever seizure he has, is it real seizure or it is pseudo seizure? And if it is real seizure, then you have to decide, is it partial or generalized? If you have reached the decision, if it is partial, you have to decide, is it simple or complex, right? And is it motor, sensory or psychomotor? Then is there any evidence of disturbed electrical activity? I told you EEG, in which I told you during the attack, EEG should be abnormal. If during a full-blown attack, EEG is normal, it may be pseudo. But in between the attack, yes, in between the attack, EEG is normal or abnormal?
No, it can be.
It may or may not be. Remember one thing. In between the 2 attacks, we call it interictal phase. Interictal phase. EEG may be absolutely normal. So normal EEG in between the attack does not rule out epilepsy. Normal EEG in between the attack does not rule out epilepsy. Number 1. Number 2. Abnormal EEG in between the attack does not confirm there was epilepsy. Because even normal people may have sometimes abnormal EEG, and the thing which was you were thinking seizure, it would have been a pseudo seizure. For example, you may end up with a 18-year-old lady and she has a tendency to undergo pseudo seizures. Sometimes it happens even in pseudo seizures, in between the attacks you may have abnormal EEG. So interictal EEG is really not much helpful. The point which I want to tell you, that it is quite possible you have truly epilepsy, but in between the attacks you do not have your normal EEG. And it is also quite possible that you are having some other disease but no epilepsy, still you may have abnormal EEG. So EEG is really helpful during the attack. Is that right? Anyway, let's come back. Now, let's discuss partial epilepsy. Already we have discussed partial epilepsy may be divided into two types. Yes, please. Simple partial and complex partial. Is that right? Here, alteration in consciousness. Here, no alteration in consciousness. Then simple partial may be yes, motor. Yes, please. Or it may be yes, sensory. Or it may be psychomotor. Simple partial, psychomotor. In the same way, complex may also be motor, or it may be sensory, or it may be psychomotor. Now, again it can be subdivided. Motor cases may be yes, tonic, or clonic, or atonic, or tonic clonic. Myoclonic usually taken as generalized, right? And akinetic or atonic. Now, again, let's come back. If my hand is like this and suddenly it becomes stiffened, what is it? Only one hand. It is? Who told you it's simple? Maybe I'm dazed, I'm looking like this, it means my consciousness is altered. It is partial, bus. And it is motor, bus. Then you have to look at my conscious level, and it's not necessary that for disturbance of conscious level I must become totally black out and fall down. Many people have altered consciousness, still they don't fall, right? So you have to check out number one. Listen carefully. My hand becomes stiffened, my consciousness is perfectly okay, and problem remain here. What is it? Simple, partial, motor. Is that right? Now, if I'm having, and of course tonic please, and if my hand is moving like this, what is this? All that simple, partial, tonic, clonic, right? First stiffen and then move like this. If it is always like this, then tonic, clonic. If my hand loses just tone, simple, partial, atonic. And if I develop, okay, all these things, any one of these things, but with disturbed consciousness. So it means that this again, partial may be simple, partial may be complex, it may be motor, and motor cases, all these cases, they may be tonic, there may be tonic, clonic, they may be only clonic, they may be atonic. Is that right? Now we come to this thing, sensory. If I feel my hand has developed abnormal sensation or tingling, what is it? Simple, partial. If my consciousness is normal, it is? Simple. Okay, listen. When my hand has abnormal sensations as a evidence of epilepsy, number one, it is right hand, it is partial. If my consciousness is normal, it is simple. And if abnormal sensation, it is sensory. So what is this? Simple, partial, sensory. Is that right? In the same way, psychomotor. Then, if with that sensory experience I have disturbed consciousness, it is complex, partial, sensory. Now we come to another thing, psychomotor. For example, a person develops, feeling of déjà vu. Déjà vu was what? Over familiarity. Or he develops, first of all, psychomotor. What are these? Psychomotor may be déjà vu or jamais vu, which is unreality, or I explained it in last lecture. Then there may be olfactory hallucinations, or there may be gustatory hallucination, or well-formed images which are from temporal, unformed images are from occipital lobe. Then there may be automatism. What is automatism? Suddenly patient starts some automatic activity. Is that right? One patient which someone told me, there was a girl about 11-year-old, and she had a habit to spit on anyone at any time. And she was unfortunately beaten by the family and given incentives not to do this, and family was very disturbed. So when the doctor asked the girl that what's wrong, she said, I don't know, I'm not aware why I do it. And she has been beaten a lot previously, and mother was also depressed that other females in the family tell she is not raising her daughter properly, she will spit on everyone in the future, vagara, vagara. Now, she was just given anti-epileptic drug and she was perfectly okay. Which area of the brain was disturbed? Temporal lobe. Eating behavior and spitting behavior is in the temporal lobe. So that was one unusual manifestation of temporal lobe epilepsy. Or you may end up with a patient that who suddenly starts spinning around, and during that patient is not aware but spins for a few circles and then stop, and every 2-3 days auto spinning start. That is another example of automatism. That is also a case of psychomotor epilepsy, right? So I told you psychomotor epilepsy is so many types. If during the psychomotor epilepsy patient retains his conscious level absolutely normal, then it is simple partial psychomotor. If patient is slightly disturbed conscious level, then it is simple, no, not simple, yes, complex partial psychomotor, right? Then we come to another thing, and you have learned this thing. Many times what happens, patients start as one of these partial situation and then all the body undergo tonic or clonic situation. What has happened? Partial has become generalized. So there is no fun in telling that there may be simple partial which convert into complex partial and eventually became generalized. Generalized means that patient started with one focal problem, electrical discharge, then both hemispheres started. In case of becoming generalized, there is always alteration in consciousness. So there is no simple case of generalization. Is that right? Simple may become generalized, but truly generalized, we start as generalized, both hemispheres fire automatically, it probably start from diencephalon. Is that right? And when the diencephalon start abnormally firing, both hemispheres at a time simultaneously start firing abnormally. Is that clear to everyone? Now, here it is. Partial becoming generalized, I think there is no need of detail. Yes, generalized we need to go into detail, few words. Generalized epilepsy may be absence epilepsy. It may be, yes, very common. Absence is also called petit mal epilepsy. I will go into detail of this right now. Then there is tonic, clonic epilepsy, which is also called, yes please, grand mal. Then patient's body just stiffens, that is tonic. Patient's body is bilaterally jerk, what is that? Clonic. One muscle or small group of muscles jerk, myoclonic, yes, very good. And if patient loses the total tone, atonic. Now, I will go into detail of first two cases because last are very easy. Patient's body in tonic case stiffens and then it becomes normal. Clonic, simultaneously both part of the body, both half of the body jerk and then patient become normal. Myoclonic, one muscle or one group of muscle abnormally jerk and then person become normal. Atonic, all the body loses tone and then patient become normal. But we will go into detail of tonic, clonic and absence. You want detail of absence first or tonic, clonic first? Absence. Actually in absence seizure, most of these seizures start in childhood. These are very brief episodes of epilepsy and one day, in every day there may be multiple cases. These are very brief frequent attacks of epilepsy in which, in absence case, in which person becomes mentally absent. What really happens, for example, there is a child who is eating something and talking to his mother. During the eating, suddenly he brings the food here. He'll stop like this, remain few seconds like this. Maybe he will blink his eyes a little bit, some automatic movement. After 10 seconds, he again start eating as if nothing happened, and if he has stopped the sentence in mid-sentence, wherever he stopped, he will carry on from there. What is absence seizure? In absence seizure, what really happens, you can say patient's all activity has a pause and then again start from where it was stopped, right? These patients who are having absence seizure, they may develop sometimes hundreds of attacks per day. 3-second attack, 5-second attack, 10-second attack. Usually they are very brief attack and usually these are multiple attacks. These absence epilepsy usually starts in children. Is that right? And as the child grows up, usually they grow out of absence seizure. But unfortunately, some of them develop tonic-clonic epilepsy again. So absence epilepsy, as child age grows, he grows out of this situation. So it means absence epilepsy is basically not a childhood disease, and as children grow, they will recover out of it, but unfortunately some children may develop tonic-clonic problem with that, right? Now absence has a one very special type of, you can say, EEG pattern, and this is the only EEG pattern good students should know. You are not supposed to remember all the EEG pattern of every epilepsy, but about absence, because it's very characteristic. There is spike and wave pattern. The spike and wave pattern. Spike and wave pattern. There is always a spike followed by some sort of wave. A spike, and then there is a spike, wave, spike, wave, spike, wave. And frequency is 3 per second. 3 cycles per second. The typical EEG, which is spike and wave pattern during absence seizure, right? It will be in right hemisphere or left more frequently. Of course, it is generalized. It must be on the both sides, right? Spike and wave pattern, three cycles of spikes and waves per second. Is that right? Now, what really happens that in this particular case, right? This is almost diagnostic for what? Absence seizure, right? And it is best treated by ethosuximide. It is best treated by ethosuximide. And how ethosuximide work? Reduce the calcium influx in thalamic neurons. Write it down. Another important thing which I want to tell you, that in absence seizure, ethosuximide, which is best first line drug for the absence seizure, it reduces the calcium influx in thalamic neurons, right? And actually this is a abnormal pattern of firing by thalamic neuron which make the conscious level altered, but it does not make the person hypotonia, so person does not fall down. Usually in petit mal, person does not fall down. Then we come to tonic-clonic. Tonic-clonic has different phases. Some people talk in some cases is prodrome. Then there is, yes, aura. Then there is tonic phase. I will explain every stage. Then of course there it will be followed by clonic phase, and then there will be, yes, clonic phase, and then it may be followed by post-ictal phase. Post-ictal phase. Few words about everything. Prodrome. Prodrome is clinic. It is actually, it occurs before the seizure. It is not the part of the seizure. And usually prodrome, during prodrome, patient develops some abnormality which other people can also observe. For example, behavioral abnormality or mood abnormality or some motor abnormality. So during the prodrome of a seizure, patient may or may not be aware, but others are aware of this. Then some patient go into aura. Remember, aura is the part of the seizure. Aura is part of the seizure. And aura is only perceived by the patient, not by the onlookers. As aura, there may be strange smells, or there may be strange taste, or strange gut feelings, right? Like that. So prodrome is many hours and days before the attack. Aura is just before the attack. Rather we should say prodrome is before the attack and aura is the earliest phase of the attack. Prodrome can be observed by the others. Aura is only perceived by the patient. Then we come to the tonic. During this phase of attack, person rapidly loses consciousness and all the body becomes stiffened. During this phase, patient may develop cyanosis and may have a cry. Why the cry is there? When respiratory muscle undergoes spasticity, maybe rapidly air come out of larynx and that produces a cry. And if spasticity lasts longer, when respiratory muscles are stiffened for a longer time, what really happens? Patient cannot breathe well. So cyanosis may develop. So we can say the special features in tonic may be, number one, the stiffening of the body. Number two, yes, please. Patient may cry, and then there may be cyanosis. Then we come to the clonic phase. In clonic phase, what really happens? Muscles start jerking. They intermittently contract and relax. Okay? Agonist and antagonist fire alternatively. Right? This is the phase during which not only all the body is jerking bilaterally, but there may be risk of tongue biting, because tongue is also violently moving in the oral cavity and pterygoids are also moving jaws, right? Temporalis and other muscles of mastication. So side of the tongue may be caught and badly bitten or crushed by the jaw. What is the best way to prevent the tongue biting? Yeah.
Anything shouldn't
For example, shoe of someone. Yes, there was a theory that if a person is going into grand mal, you open his mouth and put something in, maybe handkerchief or maybe some plastic or something. The latest concept is don't do anything. Unfortunately, we cannot do anything. Because when patient is stiffened, he does not open his mouth. And when he is passing through, which phase? Clonic phase. You put anything in his mouth, he will crush that and add to injuries. Right? Now they are saying that don't try to put many things in their mouth. In prodrome, yani, when patient has prodrome, it is 5 days before the attack, he should put some bottle in his mouth and waiting for the attack. It will too early. Right? So anyway, they say that it's not much helpful, even though conventionally many people believe that there should be something inserted in the mouth, but it really doesn't help much except you lose that thing. Right? Then, so to clonic phase, it is one feature that tongue biting can occur. What is the other feature of clonic phase? Urinary or fecal incontinence, where urinary sphincters or anal sphincters intermittently become tight and loose. So there may be incontinence in clonic phase. And after that, when patient go into post-ictal phase, during post-ictal phase, patient become drowsy, patient become relaxed, right? Patient become irritable. Remember, if you irritate the patient, some patient may even attack you during post-ictal phase. Right, and don't leave the patient alone during post-ictal phase, right, because sometimes status epilepticus may come, right. So post-ictal phase, patient usually sleeps during that. After many hours, patient will feel normal, right. So this was something about the different types of epilepsy. Yeah.
Sir, how can we differentiate between generalized myoclonic and partial clonic? Isn't it difficult because in both the cases only one.
Look, in generalized, what really happens during myoclonic, even though one muscle moves, right after that patient become unconscious, or during that patient become unconscious. So it means it is generalized. And with that, this was the muscle which specially responded, right? Yeah. Now, after getting this, in those questions, insert one more question. Is there anything which brings the attack? Is there anything which precipitates the attack? Which triggers the attack? Right? There's so many things which can trigger the attack. If your brain is irritable, there's so many things which can trigger the attack, and few things may be specific in certain type of patients. For example, bright lights or flickering lights can trigger the attack. Sleep deprivation can trigger the attacks. Exhaustion, emotional or physical or mental, can trigger the attack. Sometimes some certain drugs withdrawal, like you were on alcohol and you withdraw. It is not a drug usually. Anyway, if you are on alcohol and withdrawal of it irritates your central nervous system, or you are on benzodiazepine, suddenly you withdraw. Or phenobarbital, you withdraw. Sometimes trigger may be due to certain central nervous system infections, or trigger may be due to some metabolic causes. That someone develop hypoglycemia and during that, or someone develop electrolyte abnormalities like hyponatremia or hypokalemia or hypocalcemia, an attack may come. And sometimes it's a very strange thing. Some people develop epileptic attack due to noise or by music. Yes, or some unfortunate medical student develop seizures when they have to read, right? And some people with hot baths. So different patient may have different type of triggering factors. So during the history, you have to ask the person that what kind of trigger is there, and if there is any kind of trigger, that should be avoided. Another point which I want to highlight, two more points. I told you that sometimes, if motor activity start normally in the hand, and within few seconds it goes to the arm, and then the half of the body. What is this type of march called? Jacksonian epilepsy. Jacksonian epilepsy. We call it Jacksonian march. When features of epilepsy, or right, they travel on some part of the body or march on some part of the body, it means actually in the cerebral cortex, electrical activity is slowly marching, right? It may be motor Jacksonian events, or it may be sensory Jacksonian event. I don't know why students remember the motor but forget the sensory Jacksonian. But if patient has some abnormal sensation in hand and gradually it ascends upward, it must be considered as sensory Jacksonian. Another point, that sometimes after motor Jacksonian, you feel limb is weak for a while. That is called Todd's paralysis. Todds, Todd's paralysis. That is called Todd paralysis. Now we come to what could be the causes of epilepsy. If a patient comes to you, you must be able to answer following questions by now. Number 1, is it seizure or not? Number 2, is it partial or generalized? Is it simple or complex if it is partial? Is it motor? Is it sensory or psychomotor? Then you must be able to, is there any trigger or not? Then with further things you may be able to decide, is there any evidence of electrophysiological problems or not? Then anatomical. Let's go to the causes of epilepsy. I told you basically epilepsy can be divided into 2. That is epilepsy which is symptomatic, which is secondary to some underlying problem in the central nervous system, which could be prevented or could be managed somehow. Or it may be idiopathic, which is usually inherited problem of familial tendency, right? Let's go into detail of that. First of all, causes of partial epilepsy. Okay, before really we go for that, there's some very important clinical point. That if you think epilepsy is symptomatic, it means you think there is something underlying and you expect to find some lesion. So you have to be very aggressively do investigations, right? Either metabolic problem is there or there is structural lesions, right? What type of epilepsies have high chance in which you will find some underlying structural lesions? Number 1, partial epilepsies. Partial epilepsies, patient have more chances to have some underlying lesion than generalized. Number 2, adult onset epilepsy. If during childhood you did not develop epilepsy, in an adult age you develop epilepsy, it must be thoroughly investigated. Third, epilepsy refractory to the management. These 3 points should be highlighted. That when there is a high chance that in an epileptic patient you will find something, yes, some structural lesion or metabolic lesion under it, number 1. And what I am talking about, such epilepsies are having less chance to be idiopathic. There are more chances that such epilepsies are symptom of some underlying disease. Number 1, partial epilepsy. For example, tumors produced by partial epilepsy initially at least, right? Number 2, epilepsy of adult onset. Number 3, refractory to management, most of the drugs. So it means if a patient comes with, child is 5-year-old, having some generalized type of epilepsy, also family history, right? And very easily managed on drugs. What do you think? Idiopathic. It is most probably idiopathic. Is that clear to everyone? Now, let's come to what could be the causes of epilepsy. Let's see what are the causes of partial seizures. Number 1, partial seizure may be idiopathic. Of course, we will not go into detail. But they are less commonly idiopathic. Most of the partial seizures are symptomatic and most of the generalized attacks are idiopathic, right? But of course, you may come across some patient in which partial epilepsy is due to idiopathic causes. There is some underlying defect in the central nervous system, but that defect is localized. Then there may be focal structural lesions. Cause may have, some people with partial epilepsies may have focal structural lesions in some part of the brain. For example, tuberous sclerosis. Tuberous sclerosis in which there are some nodules made in central nervous system with some nodules on the skin in tuberous sclerosis, right? And those nodules may be irritating the central nervous system and precipitating epilepsy. Number 2, neurofibromatosis. You know, neurofibromatosis, type 1 and type 2. Type 1 produces neurofibromas all over the body and type 2 especially produces tumors in the central nervous system. So epilepsy will be more associated with the peripheral neurofibromatosis type 1 or central neurofibromatosis type 2. Yeah, very good. So neurofibromatosis type 2 has a high chance to be associated with epilepsy. In neurofibromatosis type 2, there may be bilateral schwannomas or meningiomas or other tumors in the central nervous system, right? And that may be coming as epilepsy. Then von Hippel-Lindau disease. VON, Hippel, HIPPLA, Hippel, LINDAU. What is this? I remember it, von Hippel-Lindau syndrome, very happy land syndrome. Happy land like our country. We are happy people. Whenever someone come to rule on us, we are very happy. He is asked to be in our eyes and in our brains. Is that right? Every leader when he come initially. So in this syndrome also, what really happens? Something goes wrong with the eyes. Some tumors form in the eyes. Some tumors form in the brain, cerebellum. And in the end, what we do with our leaders? We pass urine on them. So, patient develop renal complication. Von Hippel-Lindau syndrome. Very happy land syndrome. Where whatever leader comes, pehle sar aankhon pe, and eventually piss on. Yes, right? So, very happy land syndrome or von Hippel-Lindau syndrome, the tumors in the eyes, retina, the tumors in the central nervous system, and malformations in kidney. I will teach you in detail in patho. Right? So, von Hippel-Lindau syndrome, if there are some structural lesions in the central nervous system, of course, they may become epileptic focus. Then we come to dysembryonic problem. Some part of the central nervous system did not develop properly during the intrauterine life. Migration of neuronal group was abnormal, right? For example, cortical dysgenesis during intrauterine life. Development of the brain was not normal in a focal area. This may end up into cortical dysgenesis. Then there is another situation which is called mesial temporal sclerosis, MESIAL, mesial temporal sclerosis, in which you do MRI basically and diagnose this case that one temporal lobe is sclerosed, right? The very important thing about this is that sometimes it has to be treated by temporal lobectomy. Sometimes it needs to be treated by temporal lobectomy. Then there can be cerebrovascular events. For example, there can be thrombotic, what? There can be thrombotic infarction, or there can be embolic infarction. You know the difference between thrombotic infarction and embolic infarction? Is there some part you don't know it? Okay, let me explain. It's very simple. Here is your central nervous system. If there is a blood vessel here, and this vessel has some atheroma here, and a thrombus form over the atheroma, then this area will undergo infarction. This is thrombotic. Or there is some atheroma in lower part, and from here, you are yourself intelligent, isn't it? Some piece of this detach and then it stick into some area, and this is what? So this is thrombotic infarction, this is embolic infarction. Sometimes what really happen, in central nervous system, draining veins are thrombosed. You know, the dural sinuses and veins are thrombosed, right? They may also produce epilepsy. So, case number A, choice number 1, I'm going to give you a question. There are 3 different types of cerebrovascular accident. Number 1 is thrombotic, thrombotic infarction, cerebral infarction. Number 2 is embolic, cerebral infarction. And number 3 is, what is that? Cerebral vein thrombosis. What do you think? Which patient has maximum risk of epilepsy? I'm about to be impressed by someone out of you. Very commonly they make an MCQ on this thing, because in America population is getting senior citizens. They don't let their people die. They keep on hanging them with the medical facilities. So many people are now suffering with the different type of cerebrovascular accidents, right? Now, for example, patient number 1, he is suffering. For example, you have 100 patients with problem number 1, 100 patients with problem number 2, 100 patients with problem number 3. Which group of patient has highest chances of having the epilepsy? Anyone? Number? I don't know, 1 or 2, you have to decide one thing. Okay, people who believe it's number 1, raise their hands. Very few. People who believe it's number 2. And is there anyone who believes it's number 3? Yes, this is only right answer. Yeah, number 3. Actually, it has the least chance of presenting with epileptiform situation. It has more chance, and it is the most frequently presenting with epilepsy. Very frequent attacks of epilepsy, right? Because when a vein is thrombosed, there are multiple areas in which congestion develop, and those areas become hypoxic but not dead. Those neurons are hypoxic but not dead. When they are not dead, when there is hypoxia, low oxygen is there, low ATP is formed, sodium potassium ATPases are not working, sodium accumulate into these neurons, and the multiple neurons with cationic loading and which fire more. But in case of first case, thrombotic infarction, if there is occlusive thrombi, either neurons live or they die, and dead neurons don't have abnormal electrical activity. Am I clear? You got your answer? Thank you. She was asking why thrombotic vein problem produces more chances of epilepsy than this one. Here what happens, if a thrombus form occlusive thrombus, the dependent neurons will die. Dead neurons don't produce epileptiform focus. But in this particular case, when a vein is blocked, many large group of become congested in the brain because venous blood cannot be drained well. But where there is congestion and stasis, hypoxia develop, neurons are living but extremely hypoxic, so they develop firing abnormally. They develop abnormal firing. Okay, then we come to, of course, another choice was AV malformations. Arteriovenous malformations, they can also present with what? Epilepsy, right? Usually with partial epilepsy, right? Which area in the which artery in the central nervous system has the highest chances of developing abnormalities? Congenital or acquired? Please tell me circle of Willis. It develops very commonly barrieaneurysms. There was something in pathology like that. It is still there, right? So barrieaneurysms, you heard of them, right? They very commonly develop in circle of Willis, and when they rupture barrieaneurysm, they produce thrombotic infarction in the brain, or barrieaneurysm when they rupture, they produce embolic. They produce hemorrhage. What type of hemorrhage? Very good, subarachnoid hemorrhage, not a thrombotic or embolic problem. One of the very important causes of subarachnoid hemorrhage is barrieaneurysm rupture or AV malformation rupture. Subarachnoid hemorrhage, how it presents, what patient will come to you? Patient will come and tell you, doctor, you see, I have subarachnoid hemorrhage. Yeah, the worst headache of his life, right, followed by what? Features of raised intracranial pressures, and in lumbar puncture, of course you should avoid lumbar puncture if there is raised intracranial pressure. If raised intracranial pressure is yet not there, in the lumbar puncture you will find RBCs. Is that right? Okay. Now, then there may be tumors in central nervous system which can produce partial, and in the tumors you must remember the best investigation is CT scan or MRI? MRI is better or CT scan to find the smallest structural lesion? MRI. So small gliomas are usually missed on CT scan, but they can be detected by MRI. So there is tumor in some part of the central nervous system that may lead to partial epilepsy, or trauma in some part of the central nervous system may lead to partial epilepsy. Then some infective processes which are usually limited to one part of central nervous system, they may lead to partial epilepsy, right? Now in this particular case, number 1, cerebral abscesses. What is the most common cause of cerebral abscess for the central nervous system? Otitis media. Chronic suppurative otitis media, because otitis media is in the middle ear cavity, in which the tegmen tympani, which is the roof of the middle ear, is one of the very thin bones, and cholesteatoma can break that and take the infection up. Cerebral abscesses. Then there is a disease called toxoplasmosis. What is this disease? How you can get that? From the torch you can get it. It is one of the torch. The cats you get it. Toxoplasmosis usually you acquire from the cats. Cat lovers get this disease. This is which bacteria? What type of bacteria? It is not bacteria, it is parasite. First tell me this is parasite and this is Toxoplasma gondii. And okay, you are so too good in this disease. It usually involve which part of your body? Number one, central nervous system. Number two, look, okay, I will put a question to you. There is a patient who is suffering with HIV and AIDS and he developed complications related with Toxoplasma gondii. He has some complications in central nervous system and some other complications. Retina, Toxoplasma gondii especially attacks retina. And if you are so good, then you must tell me which is the best drug for Toxoplasma gondii in the eyes. Yes, Alam. No, he is right. What is this you told? Trimethoprim and sulfamethoxazole. You are right. He is right. Sulfur drugs. Anyway, then in central nervous system there is another disease can attack which is called cysticercosis. What is it? Cysticercosis. It's a parasitic disease from tapeworm. It's from in India and our country it's a bit common. From tapeworm there you can say what goes to central nervous system? Larval form, I think, cysticercus, and usually they go to central nervous system and they get calcified in central nervous system. This is the only cause of epilepsy which can be diagnosed on X-ray. Cysticercosis, right, in which larva of the tapeworm goes to the central nervous system. Which tapeworm? Pork or cow? I mean Taenia solium or Taenia saginata. Taenia saginata is coming from cows and Taenia solium is coming from pork. So which one goes up to the Taenia solium? That's good. That's good. So cysticercosis usually larva gets over there and then it may get calcified and can be diagnosed in. Then tuberculomas. There's no fun in telling tuberculoma is the granuloma of TB, and some tuberculoma may be irritative to some part of central nervous system and produce a trouble over there. Then inflammatory. Then other infections like subdural empyema. What is subdural empyema? Empyema is collection of pus which is not free because adhesions are developed around and sealed off. Then encephalitis, especially temporal lobe encephalitis. What is the common cause of temporal lobe encephalitis? Yes, very good. Herpes. Excellent. And very commonly they ask a question that when you develop temporal lobe problem with herpes, you develop hemorrhagic lesion in temporal lobe. This is a very common. Yeah? Bilateral. You are yourself intelligent. People have intelligent friends. Right. Then HIV, AIDS. If it involves central nervous system, it may produce inflammatory conditions and that may lead to partial epilepsy. Then inflammatory conditions in central nervous system like sarcoidosis. You know sarcoidosis? Sarcoidosis. What is sarcoidosis? Who will tell me? What is sarcoidosis? It's a immune mediated granuloma formation. Excellent, in which there is no caseation. This is how it can be differentiated from tuberculomas. Excellent, very good. Then vasculitis. If someone develop epilepsy because there is vasculitis in central nervous system, very bad association is SLE. It's one of the most dangerous complications of SLE when person develops cerebral vasculitis and death is almost always there. Vasculitis due to SLE. Vasculitis means any antigen antibody complexes get deposited into some vascular lining and then they activate the complement and neutrophil and macrophages and vasculitic lesions form. It's so simple. It's so simple that it should not be asked. But anyway, if you want, I can explain. You know, if some blood vessel in cerebral circulation, cerebral area, if it develops vasculitis, it becomes inflamed. If it becomes inflamed, dependent area will become ischemic. Ischemic area will have more oxygen or less oxygen. If there is less oxygen, what happened to more ATP, less ATP? If less ATP, sodium potassium ATPases will work more or less. So whatever sodium goes into neurons, can you push it out? No. So gradually neurons become loaded with sodium or other cations, and then they have more chances to fire or less. It's so simple. Hypoxia or ischemia, both are irritative to central nervous system. Okay, now we come to the causes of generalized epilepsy. Generalized epilepsy, right? Number one, genetic causes. In this case, genetic causes may be inborn error of metabolism or storage diseases. Have you heard of a disease called Tay-Sachs disease? Right? Some storage diseases which in the neurons some abnormal substances accumulate, and these substances accumulate in neurons all over the central nervous system. And if these substances are accumulating all over the central nervous system, then it means that they are leading to generalized epilepsy. Then cerebral birth injury. During the birth process, there is some hypoxia or damage to central nervous system. This hypoxia may produce multiple abnormalities in central nervous system, and baby may develop generalized epilepsy. Then hydrocephalus. Hydrocephalus will affect only one part of the central nervous system or multiple parts. So it may lead to generalized epilepsy. Then due to any cause, there is prolonged cerebral anoxia. For example, you develop very prolonged hypotension, and there is severe prolonged anoxia that may be clinically coming to fits or seizures. Right? Then there are many drugs which irritate the central nervous system. Right? I will not tell, of course, all of them, but especially in antibiotics, you should know one group. I think penicillins are more important. In some patients, metabolites of penicillin block the sodium channel, then calcium channel, block the GABAergic channels, in chloride channels. So neurons become overactive. Right? Then antimalarials can do that. Isoniazid can do that. Cardiac antiarrhythmics, of course, cardiac antiarrhythmics are dealing with the excitation of cardiac tissue, and if they go to central nervous system, disturb the electrical activity in CNS. Right? Then psychotropic drugs like phenothiazine, the tricyclic, they can irritate the brain because phenothiazines can stimulate many receptors in central nervous system or block some receptors. In the same way, tricyclic antidepressant, they block the reuptake mechanism of monoamines, and a monoamine cannot be reuptaken by neurons. They may accumulate in synapses. Are you understanding, or I should draw a diagram? Look, this is a neuron. This neuron releases monoamine. It may be dopamine or norepinephrine or epinephrine, right? It will act on the next neuron, then 80% of this will be reuptaken. This reuptake channel is blocked by tricyclic. So tricyclic block the reuptake of monoamines. The many drugs which block the reuptake of monoamines. Tricyclic antidepressant, then SSRIs. What are SSRIs? Serotonin reuptake inhibitors. In the same way, cocaine also block reuptake. So these drugs which block the reuptake, actually they increase the concentration of what? Monoamines. And sometimes if irritative concentration are very high and irritative, epilepsy may precipitate or seizures may precipitate.